is Rodrigo Ruano. I'm the chair of the Maternal Fetal Medicine Division, Mayo Clinic, and director of the Fetal Diagnostic Therapeutic Center at Mayo Clinic. And then I'm the first author of the present article that we're going to discuss here, which is the fetal endoscopic tracheal occlusion for congenital diaphragmatic hernia as part of regenerative medicine.
This will be published in the Mayo Clinic Proceedings. I'm Dr. Denise Klintner. I'm a co-author with Dr. Ruano and one of the pediatric surgeons here at the Mayo Clinic.
My name is Courtney McCauley. I'm a neonatology fellow here at Mayo Clinic.
So the present article demonstrates that first of all, Mayo Clinic has expertise to perform fetal therapy to improve the lung conditions, the lung growth of the fetuses in utero. So the object of this article is to show that we implemented successfully the fetal therapy program at Mayo Clinic, and secondly, that the treatment that we are doing here is to make the lungs bigger, grow. So this is a very good example, a practical example of regenerative medicine and fetal therapy, which is very new.
I think it also demonstrates the collaborative nature of Mayo Clinic and how all the different teams worked well together to have an excellent outcome for both of these.
So congenital diaphragmatic hernia is a rare defect. It happens 1 in 3,000. And it happens when the diaphragm of the baby does not close very well. The organs, the abdominal organs, so like stomach, liver, and bowels, they come up and they block in reality the lung development, the heart a little bit. They shift the lung and the heart to the other side. And then the problem is that because of the lungs, the smaller lungs, hypoplastic lungs, so those babies, they have higher chance of death or complications postnatally, respiratory morbidities. How do we diagnose this condition in utero? Well, we use ultrasound, and then it's recommended to all patients, all pregnant women, to have ultrasound around 22 weeks to scan and to screen for congenital problems. So we check the anatomy of the baby, and then we can diagnose congenital diaphragmatic hernia. And then once we diagnose that, those patients need to be sent as soon as possible to a center that can follow those patients and can discuss different perinatal treatment. And also, this is a very good example of service line of regenerative medicine, because we place a balloon inside the trachea that we are going to explain afterwards in the fetus and in both fetuses, and then we demonstrate that the lungs grew after the procedures. We make the lungs bigger. So that's part of regenerative medicine service pipeline here. So I think we have three main findings. The first finding is what Dr. Denise mentioned here, is that the multidisciplinary approach, and she can speak a little bit better about that. But the first is that we were able to implement a very unique program at Mayo Clinic with safely and also effectively. Because the third point is that we demonstrated that we were able to, by placing a balloon in the trachea, occlude the trachea, to make the lungs of the babies in utero bigger. So that's an example of regenerative medicine. And that's a different philosophy that we have here in Mayo, that we are applying fetal therapy to promote to develop the organs of the baby. Do you want to try to respond to that?
So the lungs are constantly producing fluid. So if the balloon is in place and including the airway, then the fluid helps expand the lungs. So infants that have a high airway obstruction are born with very large overinflated lungs. And so we applied basically what is known in other anomalies to babies with congenital diaphragmatic hernia, Originally, it was a clip that was placed across the trachea. The problem was that if they were born anywhere else, you have to get the clip off very quickly, and the balloon still has that same issue, which happened for one of our infants, where the delivery was necessarily done under a general anesthetic for the mother as an exit procedure, keeping the baby on placental support. So the infants cannot breathe until you deflate that balloon, and so having the multidisciplinary team, including pediatric anesthesia, anesthesia for mom, maternal anesthesia, pediatric ENT, pediatric surgery, the MFM team, everybody played a role in making sure that this outcome was successful.
And what she mentioned is very important, that we improved the technique. In the past, surgeons used to put clips, but it was very difficult to reverse the occlusion before or during the baby, while the babies were born. And now we use a detachable balloon that we can deflate before we clamp the cord. So we have a better solution for that nowadays.
And I think one of the take-home points, and Dr. Rowana had kind of mentioned it too, is that this article demonstrates success with a new procedure, a new technique. On the neonatology side, we consult with the families beforehand, and then also we get the pleasure and joy of following them after birth through their initial resuscitation, both their acute phase of trying to recover, as well as their follow-up clinic. And so I've seen both of these patients in follow-up, and they did beautifully. And so it's been, I think that's a huge highlight of this article.
Mayo Clinic has, my opinion, some of unique opportunities. First of all is that we can take care of patients now, before they are born, before they are born throughout their entire lives here. So that's, I think, unique. The second point is that regenerative medicine, the philosophy of regenerating organs or tissues using the technique that we have now. So our focus, for example, in the article, the babies, they did well, they survived, but what we could prove is that the lungs grew, so the lungs responded. And it's based exactly what she was mentioning, is based on our previous, with our experience with another disease, that we have a natural tracheal atresia, that the babies, they can survive nowadays with a different type of fetal surgery, but we know that those babies, they have big lungs. So we try to occlude for a moment to try to make smaller lungs, hypoplastic lungs, bigger, then the babies, they can have better chance or better outcomes with the neonatologists here.
The infants that are more severe, by definition, not only the smaller lung volumes, larger diaphragmatic defect, have historically had trach and vent requirements, as well as gastrostomy tube requirements. The quality of life for those families is quite different from the infants who respond well to tracheal occlusion. The infants who have good growth and a lower rate of pulmonary hypertension have the opportunity to leave the hospital sooner. I mean, both of these infants left very quickly after their surgery. We've had some infants that are in hospitals 6 months to a year, and so to have that also decrease the overall cost. Up front, there is an investment of the family, the mother, and risk to the baby or fetus. The outcome is worth doing all that investment in the front. I think this is very straightforward from a clinical practice, and it's something that we've instituted, and we've had the extreme. Usually the balloon can be placed, and then we can deflate the balloon in utero. Mom delivers at the usual time. Well, sometimes they go into preterm labor, and the whole team was mobilized, and were able to be successful in caring for both the fetus and the mom.
She's completely right. I think these two patients that we described showed how difficult sometimes is to manage those patients, and we proved that we were able to safely manage those patients because, as she mentioned, one of the babies needed to deliver before, so we were able to do a complex type of delivery that we remove the balloon during the C-section before we clamp the cord. So we call exit procedure. The second patient had chorion separation that was impossible for us to put another scope inside the amniotic cavity and remove the balloon. So we punctured the balloon. So we did our two first patients. We have these two difficulties that we manage with multidisciplinary approach, I think, very safely.
As far as clinically, I can speak both from my expectations. I'm a first-year fellow, so I'm new in my training, but also in talking with my colleagues and my mentors, everyone was very surprised. Nobody knew what to expect when these babies were born, and everyone was pleasantly surprised at how well they did in the resuscitation room and their recovery, which we've talked about before. And it's across the whole spectrum. I mean, everyone, whether you were in the NICU taking care of them, and now even the follow-up, I think the clinical aspect of it all has been tremendous.
Well, I think some of the things that we are hoping to avoid in the future is that chorioamniotic separation. There's different techniques that we can do to avoid that or to mitigate how badly it happens. The balloon deployment, making sure that it's in one place, we only need one,
Yes.
to be effective. And then selecting patients. Are there patients that won't respond? And then how do you determine that?
Yeah, from my point of view is that I always fight for those babies. So I really want to improve the technique, improve the conditions to avoid. For example, I'm studying a lot. One of my focus is on try to prevent prematurity, rupture of the membrane. So I hope to discuss with to come up with a protocol to study how we can regenerate membranes and help treating premature rupture of the membranes, which is a prematurity and premature rupture of the membranes are the main risks that we have. The third aspect is that I'm fighting for those babies, and I really want to see if we can improve the lung growth. So I dedicate my time to studying also how we can get better lungs for those babies, even for more severe forms that we call extremely severe hypoplastic lungs. So those are my focuses now.
I actually have a unique role in this setting because one of the patients is my niece. So I have both a professional and a personal interest in this, and I can happily say that it means a lot to the families. I personally believe, and I know that I speak on behalf of my family, that believe that we would not have our niece with us, probably even alive, if it hadn't been for this fetal intervention. And even if everything worked perfectly for her, and in this case, and I'm happy to report that she looks like every other 9-month-old baby. You would never know anything was wrong other than when you look at her little surgical scar from her surgery.
Which will be fine,
yeah, and it'll be beautiful in a bathing suit. But so for our family personally, it's meant a lot, and I also, as I commented before, it was a joy. I also got to see the other patient in the NICU follow-up clinic. He had gone home on a little oxygen, and he was off of his oxygen in the follow-up clinic a couple months later, and his family was very appreciative and rejoicing as well. Again, a beautiful baby that you would never even have guessed had such a severe diagnosis prenatally. And so it's exciting what Mayo Clinic is doing here and doing for their patients and families.
We hope you found this presentation from the content of Mayo Clinic proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.